Okay, as he stands there comfortably, his left foot flares. Now that's an indication to me that the left foot is trying to support him from falling to the left. So the foot will flare out, so more than likely that's the short leg. And if you will see, he also has a flattened arch, so maybe the arch is dropped in that. So it's one thing I notice when the patient stands there when he's walking. Observation is probably 30% of your diagnosis, just watching the person come down the hallway. Could you please lay face down, please? Yeah. And if you see, you probably have like, 3/8 of an inch shortness of the left leg. First thing I do is I start at the bottom. Pedal foundation is, we all have it. We have to walk on our feet, hopefully. And things that happen in the spine start at this level and they move up the spine. So I can adjust the whole spine and fix everything where he's hurting in his neck and his low back, but if it's caused in a weight-bearing position by something's wrong with his feet, usually the bones that are involved in the navicular bone, the talus bone, and the calcaneus, and some of the digits in the toes. If you're seeing a chiropractor and you've seen him over and over and over and over for months and months and months and you're just not getting the results you need, then you probably feel good when you leave, but a day or two later, like, oh man, it came back again. Now, if this happens once or twice or a few times, that's acceptable. But if it keeps happening chronically over and over, there's something missing, that he's not holding his alignment. He's not holding his structural integration. He's not balanced, because gravity is going to continue to throw a person out of alignment. As soon as you walk, gravity pulls you one way or the other if you're not balanced at the feet. So you have to start at the feet. You have to. I dorsiflex the feet right here. I put my hips, my thighs on his toes and flex him forward to check the range of motion. His range of motion is normal in both feet. Left Achilles tendon is loose. Right Achilles tendon is tight. Is it tender at all? More so right side or left side?
Maybe, yeah. Yes.
Right side?
Yes.
Right side's much more tender. Just a little squeeze of the Achilles tendon usually involves the whole calf muscle and gastrocnemius muscle also. Now this Achilles tendon starts here, calf comes all the way down, okay, forms the Achilles tendon and hooks onto the foot. The main bone here is the navicular bone, okay? It makes the plantar arch, and very often the cause for plantar fasciitis, not the fascia, not the muscle, not the tendon, not the soft tissue. This bone is the cause of plantar fasciitis the great majority of times. You can have hundreds and hundreds of treatments. If you don't fix that navicular bone and put it back in place so the arch doesn't drop, okay, so this doesn't change, then you're never going to really fix Achilles tendon problem. You're never going to fix plantar fasciitis. Antonio Gates should know this, but he doesn't. He's that football player that's had that plantar fasciitis, although I think he's got other problems. So take the calcaneus bone, lift it. This is a speeder board. What this does is drops to adjust the foot. So I zero in right on the navicular bone, tap it into place. That then frees up the calcaneus. We get to the calcaneus, tap it into place, put the speeder board back. Always put stuff back where you find it. All right, now we retest him. Okay, dorsiflexion again is good. Compress the left Achilles, right Achilles. To me, objectively now, I feel much looser Achilles on the right now than I did the first time. Do you?
Yes.
Okay. Tender?
Not bad.
Okay. It decreased the tenderness, and this is an immediate. It won't completely take it away, but once you take the stretch away, it should reduce it significantly. How much less is it?
Probably at least half as much, yeah.
It's at least half as much better. One adjustment, correcting the structural problem in the foot that affects the tendon that goes up the leg, either the plantar surface or the Achilles. Okay, recheck the leg lengths. Leg lengths are now even. So the adjustment of the foot evened his leg lengths. Very often you are told that you have a short leg and a short leg syndrome. When young kids get short legs, it usually develops into a scoliosis. One leg shorter than the other, you get thrown to one side and you compensate and you get crooked. and they use braces, they use surgery, they use some archaic techniques, usually you find something wrong with the foot. Usually. You correct the foot, it helps correct the discrepancy. It helps give you balance with gravity so you're not leaning one way or the other. Right now, he was about 3/8 of an inch short, perfectly even, and all I did was touch his foot. Okay? Flex the left knee, pain in the knee or the hip?
I just did squats yesterday.
He squats yesterday, so his quads are tender. All right. I'm going to flex this one. Now, this is a flexion of the knee. He has resistance right here. That's, a good 16 inches. Flexion here, he has 6 inches. So the quad on this side will not release. So he has restriction of motion and flexion in the prone position, which is face down. In my opinion, it has to do with the pelvis rotating. The quadricep muscle attaches to a bone portion in front and the front of the knee. Part of the pelvis in front and part of the knee. So if the pelvis shifts, the quad gets longer. If the quad gets longer, it stretches, which means when you go to stretch it more, it doesn't want to stretch because it's already been stretched too far. It says, stop, leave me alone. So I know now he has an anterior pelvis, which means this side is lower than this side. Flat buttock, protruding buttock. You walk down the street and one part of your butt's flat and the other is protruding. That's no good, especially for a female. And usually it's coming because your pelvis is out of alignment. So we want to bring the anterior pelvis forward with a block. Put a wedge here. So that just brought the pelvis up. I don't know, does that help at all? Yeah. Just the block increased 10 inches in flexion of his knee. Well, I can't leave that block there all day. I can't have him walk around with the block. So what I'll do is correct this deficiency. This side is back this way, so I'll tap it forward, take the block out. This is almost like a cooking show, isn't it? Take the block out, put this forward. Okay, so now we have an even pelvis. This isn't anterior flat anymore, it's even. But when this happens, some other things happen. Because the pelvis is made up, you got the hemipelvis, is the whole pelvis on the right, the whole pelvis on the left. You have an ischial tuberosity, an ischium here, and you have the tailbone and the sacrum. So when this all moves, these other products have to move. So if we go over here, here's the sacrum on the left. Here's the sacrum on the right. Sacrum on the right is down. Sacrum on the left is up and over. Well, I can't leave him that way. If I don't correct this, he gets up and starts walking around. This sacrum, or he starts exercising, and the man exercises like a professional athlete, this sacrum is going to throw out the hips and the pelvis, the feet and knees, and everything's, doc comes back the next day, hey, Dr. V, I was okay for a day, man, everything came back because I didn't complete the complete adjustment. So now, the table's a drop table. I'll contact the lateral surface of the sacrum, tap it over, then the ischium is high here and low here, low, high. So you get the ischium, tap it, man, I just felt that just shift. So then we retest it without the block, and boom, there's 6 inches, and there's 6 inches. And probably less stress, right, yeah, on your quads. So now he's balanced. So now we can stop. Nothing else can be wrong, correct? Well, he's got a sweatshirt on, which makes it a little bit difficult, but it doesn't matter. I'm going to palpate the spinous processes, each vertebra, and see which ones are moving and which ones are not. He can have a sweatshirt on, he can have a coat on. If I can feel the tip of this vertebra, that's all I need to feel. Right here, that vertebra is not moving. When I rock his pelvis, this vertebra is not moving. Tip of the scapula, T9, so I just tap it in place. Move up the spine. Rest of the spine feels good. A little bit too much of a curve here, which is the thoracic spine. A little bit of a kyphosis. We talked about that last time he was in, about his exercise programs, and don't stress this back so much. That also makes more of a curve in the cervical spine. Let's check the cervical spine, which is the neck. Some resistance, so we're going to have him lay on his back. And we'll check him from the front. Now we're going to check dorsiflexion again. To me, good, feels normal, relax. A little resistance on the right side. Tell me what you feel. Now I feel good dorsiflexion here, but I feel a little pinch there. Is that?
Yes.
Yes? Okay. So that's the talus bone. And this talus bone here is a little too forward. So what I do is I make it go this way and put it in place. I'll have to do it on the other side. Okay? Come on. And he'll feel a little click, okay, which means we put the talus bone back in place. We redo it. Yeah. Completely freed him up. We move up. This is the tibia, the big thick bone of the lower leg bone. And we want to see the tibial tuberosity, which is right there. Okay, this tibial tuberosity, if you draw a line, has to be on the outer third of the kneecap. This tibial tuberosity has to be on the outer third of the kneecap. He got good knees. From what I see, he's got good knees.
Yes.
Yes, okay, fine. Okay, now we're going to check the hip, bend your knees, right knee. Okay, this is what most of the athletes have because they run and they push and they lift weights and they push. It's all explosion. So the hips get all out of alignment and then less development anteriorly and more development posteriorly. Come on now, relax. So I'm going to roll the leg, the foot in, come on, foot in, which causes an external rotation of the femur. Then I'm going to roll the femur, the foot out and the femur in. This is internal rotation. This is external rotation. He has a nice hip on the right side where he has good internal rotation. He's a little tight in external rotation, rotating the femur because his butt muscles are tight. Piriformis and gluteus medius and those muscles, they're not allowing him to go a lot in external rotation. Not necessarily abnormal, especially if he's athletic, because they're going to fire with that muscle. You don't want to make it too lax. You don't want to make it too loose. It's got to stay taut, toned. Bend this leg. Okay, external rotation, pushing this toe in, rotating the leg out. There he is, 45 degrees, symmetrical with the other side. Internal rotation, not so good. So this side was like a 60-degree internal rotation. Here he's stopping at about 30. Usually that's because the head of the femur, or the hip bone, isn't sitting into the hip socket the right way. Okay, and the pubic bone is the bone in front that's connected to the pelvis and is part of the whole pelvis, which also affects the acetabulum or the hip socket and its angle. So if we come over, and they get a little nervous when I do that adjustment, of course, and tap, just to give a tap of the pubic bone, okay, then it brings him into, 70 degrees. So that little tap brought him from 35, 40, whatever it was, to 70. This is something I can't affect by trickery. It was bone to bone, okay, because when that head of the femur starts rotating, it'll hit part of that acetabulum. It'll just stop rotating because it's sitting crooked. As soon as you do the pubic bone adjustment, it rotates the hip socket, and all of a sudden now the hip bone can just rotate. So now he'll be able to do more and be better on his left side. Exciting, isn't it?
Yes, it is.
All right. They took my chair. Where's my chair? Oh, here's my chair. So now I'll sit in my chair and we'll check at the neck. May I take your hat off, sir? You would have got all dressed up and everything if you knew this was going to happen today, didn't you? He was just sitting in the waiting room. We pulled him out. And do you want to be on TV today? And he kind of, yeah, okay. So we appreciate it. Thank you very much. You don't get paid for this, by the way?
No.
Okay, fine. So now we come up to the occiput in the neck. Now the head's about, 10 to 12 pounds. Some people maybe 30 pounds, and some people 1 pound. But on an average, the head weighs a certain, 10 to 12 pounds. If I fix everything and I don't fix the head and how the head's articulating with the neck, and I walk somebody out of here like, hey, I feel great, doc, but my head's tilted this way. Well, the next thing they're going to do is go like this to tilt their eyes, because the eyes want to see horizontal. So if the head's tilt, they'll do like this to even out and do a horizontal on their eyes. Well, as soon as they do that, you can subluxate, or you can get out of alignment from the head down to the bottom, to the feet. Everything works as a unit because of gravity, because how God made your body. There's a pattern that we all have. When we have 2 feet and we walk, we have a pattern. Period. You have a pattern. It never changes. You have to figure it out. And it's extremely the same in everybody. It's very consistent. If it's an out-of-pattern finding, then it's more of an injury or non-compensatory. You have to look a little deeper because there's some other underlying problems. But if it's a compensatory pattern, you can see it, you can fix it. He's much better. So up here, his mastoid, this bone here, it's called the mastoid process. It's at these little tips here of the skull. The mastoid process on the left is right here, right here. So it's like this. So his skull bone is sitting back and over. His whole skull is sitting like that. So I can't leave him this way. So do I adjust the skull? I could. The easier thing would be go below the skull to the first cervical vertebra right there. Doesn't feel good, does it?
No.
No, doesn't feel good, okay? And if you adjust the first cervical, which is the atlas, which is out almost all the time in everybody, just a little gentle tap, okay? Just a gentle tap. But more importantly with the atlas, for chiropractors or non-chiropractors or whatever, it doesn't take a lot of force. You don't have to have heavy neck rotation. That's what causes injury and damage. Don't let people do that to you. It's a little tap, okay? Boom. You use your fingers, your wrists. You don't slam somebody with your hand. So I isolated and locked the first cervical. So when I rotate his head this way and go in hyperextension, I lock that vertebra. No other vertebrae move. So now, because the first cervical was out, we go to the second cervical, which is one below the first cervical, right there. We lock it, boom, come on, tap it. I don't know if you could hear the sound, but it clunk, clunk, there's an audible release. Painless?
Yes.
Painless? Actually, thank you, I feel so much better. So now, the purpose I did that was to see if I could use those 2 vertebrae and put them in place, which would balance the skull on the plateau of the first cervical. See, the first cervical vertebra has kind of 2 little plateaus, and the skull just sits right on top of it, and it slides one way or the other. So instead of hitting the skull, okay, to try to adjust the first and second cervical, I adjust the first and second cervical to try to balance out the skull. Tricky, but easy. Okay, now he's perfectly even. Right now, his whole spine is adjusted, and the next thing I would check is correlation in the ribs and the shoulders. Okay, and I'll have him sit up to do that. Now you have to be on camera. Come on up. You need your hat?
Yeah.
You look good, man.
All right.
Swing your feet this way. Sit. Oh, let me fix this. Jeez. These guys, photographers, screwed up my office. That's it. Good. So, straight ahead. Okay, second rib. Ribs up here? Yes. Look. Can you get a close-up right there? First rib, second rib, third rib. First rib, second rib, third rib. The ribs.
Hold on, let him readjust back.
Got it. Here are your ribs. They start here. First rib here, second rib, okay? Scapula, clavicle. Brachial plexus, shoulder. Always, when you have a shoulder problem, you always have to look at clavicle, scapula, first, second rib. In 40 years of practice, at least 8 out of 10 of all the shoulder injuries I've seen always had Clavicle, scapula, no, 90%. Clavicle, scapula, first or second rib, always. Why? The head of the humerus comes in here. Okay, there's a coracoid process and an acromion process, two little bones. All these muscles attach to these two little bones to make the rotator cuff. That's why it's such a marvelous joint, because it's mostly not a joint, it's mostly muscle attachments, a cuff, okay? Well, these muscles that come in to form the cuff originate from the original point, which is clavicle, first rib, second rib, scapula, period. The first and second rib move, clavicle and scapula move, vice versa. They work together, remember, as a complex. Right side moves, left side moves. These ribs move, below it has to move. So these 2 points here, where the head of the humerus comes up, can shift. Well, that's now an abnormal shoulder. So you're getting a lot of pain in your shoulder, which is symptom. Gee, I can't seem to get this shoulder well. I've been to physical therapy 352 times. I've had 2 surgeries. They can't figure it out. Okay? Fix the receptacle. You take this bone, put it here, this bone, put it here. Now, head of the humerus sits in perfectly. Well, question is, how do you put this bone here and this bone here? This bone here comes from the clavicle. This bone here comes from the scapula. Well, I got to adjust the clavicle and the scapula. Very right. But primarily, it starts in the first and second rib. So you got to do first and second rib, cervical spine vertebra, C7 or T1, cervical or T1 that goes along with the ribs. Also the clavicle and the scapula, and then maybe on the same side of involvement, the 4th, 5th, and 6th ribs. 90% of the time this is involved. Your shoulder's not getting well, have them look at your ribs. I guarantee it. It's going to correct your problem. Guarantee it. Needleless surgeries. Many, 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 many needleless surgeries. So let's check his clavicles. These are the sternoclavicular joints here. You end up being a great subject, man. You know, thank you. I appreciate it. Left sternoclavicular joint here. Right sternoclavicular joint here. Guess what? Left sternoclavicular joint is higher than the right SC joint. So now, I check here, he's got a high second rib here. I think because of the look he made, it hurts. He's flat here. He's flat here, and he gives. The first, second, third, and fourth ribs are called bucket handle ribs. They lift like this. So when you breathe, the ribs come up, and they have room to expand. If you're having breathing problems when you're sprinting or running, check the first 4 ribs, because your lungs aren't coming up into this cavity to be able to take a deep breath. Or you take a deep breath and you go, ah, man, it pinches in here. I better go take a pill. No. Go see your chiropractor, right? Second rib here, very high and protruded, very tender. All right, now, clavicle, sternoclavicular joint, low on the right, high on the left. We'll come down here to the clavicles. Now, the scapula is high on the right, and this is low on the right. So it's compensatory. So clavicle, low. Scapula, high. They come together here at the AC joint, a acromioclavicular joint. So it rotates normally. Now, if the clavicle was up and the scapula was up, we got another problem called impingement syndrome, which can also be fixed. But this is compensatory, all right? So what I do, is I give a second rib tap. You probably never heard of it because I invented it, all right? We hold his head and we hold it slightly, and we tap the second rib. Now, that loud sound was the table, not his neck. Now, the neck may or may not, or the rib may or may not go click, clank, or whatever, but it'll slide into place every time. So let's double check it. Okay? Completely different feeling, am I right?
Yes.
See, when I touched this rib the first time, it was stuck. It was like pushing on a bone that wasn't moving. So I tapped it in place. It doesn't take a lot to move it, because why? It's a bucket handle. So I just want to tap it like I would a bucket handle and knock it down. So now it's moving. Let's check the clavicles. Lined up perfectly. Scapula, lined up perfectly. I could do a series of muscle tests, but this isn't for instruction to doctors of how to do this. Okay, you can do all these muscle tests to confirm it to the patient, but I think by me touching it and taking it away and he's feeling better,
Yes.
yeah, and I think that's probably enough. I don't have to impress him with a 28, 25 muscle test. You got to come through the other door. So also, there's a little something on the right side on your back. Come this way. So now we're going to do the rest of his ribs, which is the third, fourth, fifth, and sixth ribs on the right side. Okay. And put those ribs in place. Now sit up for me. Swing this way, sir. We'll finish him off with just a little tone, nice little stretching. Open up, serratus antis, rib adjustment. Hands behind your neck and lock your fingers. I don't know if everybody needs this, but I just got a habit of doing it all the time. With guys who work out all the time, he's muscular. This guy's hard as a rock, man. He's a strong guy. Feels good, opens him up. Correct?
Yes.
Then, because it's early in the morning, hadn't had his coffee, we'll give him an ear adjustment. Then I'll say thank you very much. God bless.
Thanks.
And we'll see you next time.
All right.